Welcome to the next installment in AlertFind's webinar series. Today we are doing Improving Emergency Communications under the Emergency Preparedness Rule. Are you ready? And we are going to be live tweeting this webinar at alertfind.com. And if you'd like to join the conversation, you can use the hashtags emergency communication or AF webinar. I'm so thrilled to introduce you today to our presenter, Meg Nash, MPH. She's an emergency preparedness expert. Meg Nash is the principal consultant for Helion Solutions, a seasoned business continuity professional with a comprehensive background in emergency response, disaster preparedness, and public health. She's worked with businesses to implement continuity plans for more than 10 years and has more than 20 years of experience in emergency management and response. Meg is a certified FEMA instructor and a highly rated speaker and presenter. She holds a Master of Public Health and a graduate certificate in emergency management and public health, both from George Washington University. And I will be your moderator today, Danielle Ricci. I'm the Senior Director of Marketing at AlertFind. Welcome, Meg.
Thank you so much. I'm looking forward to this. This is certainly a timely topic, so thank you.
So today we're going to cover how to create a communications plan compliant with the CMS Emergency Preparedness Rule, the crucial role two-way communications plays in an emergency, the unique challenge that healthcare organizations face continuing operations during an emergency, why their emergency communications plan must include community partners, and why they must exercise their communications plan as part of it overall training. So I'd like to kick it off by asking you a background question. Tell us about the CMS Emergency Preparedness Rule and what role communication plays in it.
Sure. So CMS has created this Emergency Preparedness Rule, and as all things in the federal government, it took a really long time. This was driven by the outcomes from Hurricane Katrina. The original draft was put out in 2010. And, we can certainly see it's been a long time since then, but there have been a lot of iterations. CMS played a lot of, and CMS is the Center for Medicaid and Medicare. And they really paid attention to public comment. So this is something that's gone through a lot of iterations. Every time a new version came out, there were a lot of, updates and changes. And really, what we're trying to do is create this level playing field among healthcare providers across the country. But specifically within a community so that everyone can work together, hopefully somewhat seamlessly, so that we can return patients to care, we can protect business continuity, and make sure that our staff and our patients are safe during a disaster, and then obviously through recovery. One of the things that CMS did within this emergency rule is they broke out sort of four major buckets of requirements. The way they phrase them sounds a little daunting, but basically the first one is risk assessment. So here we're deciding whether it's our hazard vulnerability analysis or if we've got information from the county about what things potentially could affect us. It's really where we're going to start and decide what are the things we need to plan around. What do we need to protect ourselves from? What's my organization most likely to suffer downtime or loss of revenue from, or a threat to my patients or staff? So that's the first part. The second part is then developing policies and procedures. So now that we know what we're concerned about, what are we going to do about it to really mitigate those existing or those other factors so that we have the least disruption and loss of service as possible? The third is communications. And this is really where a lot of people get stuck. And we're going to go into that in detail today. But a lot of times, people know how to write policies and procedures. They know how to follow a template for hazard identification. But when it comes down to communication, it's such a broad umbrella that I think people are really sort of taken aback by it. So within the rule, this communication section really means that you need to be able to identify everyone you need to communicate with, whether it's partners, suppliers, staff, family members of patients, the patients themselves, EMS, your county. You need to know how you're going to communicate with them and have a very detailed plan of how that's going to work so that during a disaster, we've got those communication plans ready to go so that an organization can follow it quickly and accurately and really keep the lines of communication open so that any sharing of services or resources patient transfers and requests for assistance can get through quickly. So that's really the third part is we have to make sure that once we're in the thick of it, that we can communicate those needs back and forth. And then the last part is training and exercising. And it's a bit of a confusing area for a lot of people because the way the rule was written was not necessarily with exercises in mind. It wasn't an exercise, a typical person who does exercises that really created some of that language. So it's been a challenge to kind of detangle those things and figure out how to meet those obligations. But we're getting there. We worked with a lot of the surveyors and gone through training and some of the surveys with them, and really getting a much better understanding of what they're looking for. But communications really seems to be the part where people are, sort of left scratching their head, not sure exactly where to start or what's supposed to be in a plan.
And I want to set the stage to talk about the importance of communication by citing this fact. Communication is cited as the biggest failure in 80% of training after action reports. Why do you think that is?
I think the challenge with communications is that most people, we communicate every day. We're communicating right now. In a very timely example, you can look at the Laurel and Yanni conversation where everybody was listening to the same file and they heard different things. Communications during a disaster, during an emergency, are very different than our day-to-day communications. And typically, I have one colleague that I train with on the CMS rule who always says, I could write the after-action report before the exercise because I know it's going to fail and it's going to be communications. It always is. And really, it's when it gets down to how do I move the accurate information in the simplest form so that I know somebody gets it and they're going to do what I need them to do. They're going to take that information, they're going to reply, whatever it is, that you're delivering what you need to deliver and you're getting back what you need to get back as quickly and as effectively without mistakes as possible. And that's really hard to plan for. It's just something that seems like, oh, I know how to pick up the phone. I know how to send a text. We've got a system. I think people sort of fall back on the relying on that it's going to be like every day, and instead it's very different, and it makes for a lot of challenges.
And how can healthcare organizations better communicate with all employees when an emergency such as an active shooter or workplace violence forces them to close down one section, but other departments must continue to function?
Yeah, that's, it's really a new paradigm that people are trying to deal with in these large organizations. This slide here shows somebody actively within surgery. There have been instances, not necessarily active shooter, but where parts of the hospital have had to be evacuated. Sometimes they'll call it a vertical evacuation if they need to move people up a level due to flooding. We recently at our hospital had a gas leak, but there were 3 patients in active surgery that they couldn't clear people out, so they took non-essential personnel out of the rooms. But that gets to be really difficult, especially something as fast-moving as an active shooter. It's got such a heightened sense of fear. It catches people off guard. And organizations have to be really prepared for and trained for what information are you going to send out? What information are you going to get back? One of the people I had in my class earlier this week, they actually had, and I hadn't seen them before, but they had these little tags that hung on their ID cards on their loop. And one was looked like a red, yellow, and green round sticker. And I said, what are those? And apparently that they could press one of the buttons, either the red, the yellow, or the green, if they needed assistance. But it was a silent way for them to indicate that there was a problem where they were. But talking specifically on a communication level, you've got to think, what information do I need from people? Do I need them to give me situational awareness where they are? I'm going to have to give them information of, OR 1, 2, and 3, you're going to stay open. We're putting a guard outside the door, finish your surgeries, or, whatever it is, however they're going to lock down and portion off. But there are also times you may want that information back from them. Are they hearing anything? Do they see anyone that's in need of help? Are they barricaded in a bathroom? And a lot of those are difficult to sort of anticipate what you could need to know. What's important is that workflow. So if you are going to need information back, when you start thinking about your communication plan, you have to say, what information is going to come back to me and how do I use that appropriately so that I can get it to an incident commander at the incident command center at the hospital, or whoever is leading a response, or to the SWAT team, what's my procedure? We see a lot of drama and things on TV of made up situations where, somebody simply picks up the phone and sends a message and it automatically gets to whoever's in charge. What we see is a lot of misinformation, and it's difficult if you don't have a clear chain of command of how that information gets routed to really get that information back and make it usable. So the ability to communicate back and forth, push information as well as get it back is critical during active situations. We saw that with the shooting at the Navy Yard in DC, where people were communicating back and forth and having people that were on scene replying back and saying, here's what we're hearing, I just saw somebody walk by. That really gave the responders a good idea of what was going on inside the building before they ever went in.
And you already started to address this, but why is two-way communication so important in these?
I mean, there are a lot of different sort of nuances to two-way communication. So we talked about one of where you're trying to understand situational awareness or give immediate information that really is it's time sensitive. You need them to lock a door. You need them to turn off a light. You need them to evacuate. But when we're talking about things, let's say, where you've got staff in different places, and you have the CMS rule, the Emergency Preparedness Rule really gets to this idea of sharing resources. So more thinking beyond our four walls. It's not my rooftop, it's my community. So if I have a critical access hospital that says, we can take half of your patients, you can send all the non-critical ones here. We don't have CT, but we have X-ray, we can do an MRI, whatever it is. You have to be able to poll your staff and say, hey, I need 10 nurses that are available between the hours of X and Y. Let me know if you're available. So they can reply. That's pretty straightforward. Other nuance gets into, do you need to know if somebody got the message? So let's say your hospital has been evacuated or is in a hot zone, and meaning that the hospital, you can't function, there's some exposure. You certainly don't want people coming to the hospital. You don't want your staff showing up, but you may want them to go somewhere else. So one thing that a lot of people forget is when we go back to that sort of phone tree model of everybody's going to call a couple of people and everybody will find out. What we find is that it's just that leaving the message. Hey, I got the voicemail. I left them a message. I've left everybody a message. Well, you don't know if they got it. And if it's a situation where you need to know that they received the message to protect your staff, if there's something going on within the hospital or any facility, if you've got to transfer patients, you really need that ability to get that information back so that you can do those things you need to do within the emergency preparedness requirements and say, we're really sharing those resources and managing and protecting our own resources.
And when you start planning, how do you identify the key stakeholders that you should bring in?
So I think I always like to start with, some people will call them special needs populations, some will call them vulnerable populations. But whenever you're doing any sort of planning that includes potentially a new set of people walking through your door, either as staff, as volunteers, as patients, we want to make sure that we understand that the community is larger than the people we normally see every day. And anytime that you have, for example, I went to school in Rochester, New York, and we had a very large deaf population. If I were going to do any planning there, I would make sure I had a representative from the deaf community that could help me with my planning, because otherwise I'm sort of planning in this sort of box that I'm not understanding the nuance of my community. If I had people that didn't speak English and predominantly spoke another language, people that shared a very different culture that we didn't normally see in my facility, I would want representatives from them as part of my planning. They may not be on my communications list that I'm going to call them if something happens, but they certainly would be part of my planning, so I understand what the challenges they may face. One of the big ones is patients on dialysis. So I would definitely look at what are those flavors within my community that I need to make sure are part of my planning. Then I would make sure that I've got, and a lot of these resources are available, and we're going to share some of them towards the end, but really talking about who are the other people within the community. So are there other places where, in the 17 provider types that the rule goes through, there are a lot of nuances of, take for example, an ambulatory surgery center. That may be somebody, an organization that, if they're going to close, if they're not going to do any elective surgeries, that you could potentially have, use as an alternate care site. You could, there are a lot of different, again, that exchanging of resources. One of the big things that a lot of folks forget about when they start doing their planning is, who are my vendors? So I was recently down in Florida, and we were talking about the effect after Irma. And what was fascinating was there's no requirement for vendors to provide you what they said they were going to provide you, which is somewhat horrifying if you're in healthcare and you've got vendors lined up. One of the biggest shortages was bottled oxygen, and I was just amazed to hear that the oxygen providers just basically said, "We'll see you after the water's down. We're leaving," and there really wasn't a way for them to communicate well. So when they called and said, "Hey, we need 10 more tanks for our home health folks," there was no way to get it because they didn't have that built into their planning. You also don't want to be in a position. I've had towns where all three of the towns have the same vendor as for fresh water if they needed it. Well, the vendor can't provide it to all three at once. You have to, but having the vendors and the suppliers at your table for planning, it doesn't have to be for the whole thing, but certainly getting their consideration of when would you need to contact them? How are you best able to contact them? Another one that you can think about are utilities. So it was amazing. There was an outage recently, and the hospital got their power back, but a long-term care facility did not. And somebody found out that they hadn't had power, and they said, "Well, did you call the power company?" And the power company, then the person said, "Well, no, they know that we're a facility that we're on the early restore list." And so they called up and called the power company, and the power company said, "Oh, how long have you guys been doing that? You're not on my list." And they had been there, over 10 years. So, making sure that you have that information as part of it, whether the utilities are physically at the table, or at least you understand from their perspective what they need to know and when they need to know it. So it's really thinking through, beyond who are my staff, who are my patients, who are their families, and really looking at that broader community that the rule is trying to get at, that I think helps start to open those up. And there are a lot of good resources, like I mentioned, that we'll share that really kind of give you a jump start on what those categories are of stakeholders and kind of take the pressure off. But every organization is going to be different, and but this certainly hopes that we can get them a little closer to the finished plan with some of these resources.
And one of the requirements of the CMS rule is that healthcare organizations include other community healthcare providers in their planning and training. How should organizations approach this?
My number one recommendation is work through your healthcare coalition. Everybody should have a coalition that's operational. We like to say that if you understand one healthcare coalition, then you understand one healthcare coalition. They're all very different. They have different levels of engagement. They're membership organizations, so it's really driven by who's part of it. But these are organizations that really should be helping to bring the entire healthcare community together. They should be helping to facilitate introductions of similar types of facilities, that you can understand what the linkages are between maybe rural hospitals, the critical access, federally qualified health centers, and really making those connections. That's really where I would probably start. Working with local public health is a great idea as well, because they're going to understand who all the providers are. So if you say, hey, we provide X, Y, and Z, and we're trying to see who else may fit in with that, they might have some really good suggestions for doing that. And then, when we do training, we understand that the emergency preparedness rule is really a heavy lift for a lot of people. If you're a joint accredited facility, you've already been through this. It may be in a little bit different format, but you've done most of these things. For the other 16 provider types, though, it's really a new thing, and they're often tasked with these more administrative things when they have actual healthcare responsibilities as well. So trying to balance those is challenging. So anytime you can do more of a joint planning, like with the coalition, so that everybody's doing it at once and can kind of get to know each other at once rather than everybody having to try to go out and do it on their own, it usually works out great. And then, when somebody calls you on the phone, you've already met them, you know them, and you're far more likely to return resources, sharing equipment, staff, because you've built that relationship, rather than somebody calling up and saying, I've got 10 patients, 2 are on ventilators, can you take them? You don't want to have that phone call once the disasters happen. So healthcare coalitions and public health are a great place to start.
And why is it so important to remain flexible during a disaster? And how does your communication strategy play into that?
Yeah, so we all know that there are failures in communications. We saw during 9/11 in DC where cell phones couldn't get through. We saw the same thing after the hurricanes last year down in Texas and Florida. Obviously in Puerto Rico, they lost communications entirely. So people said, oh, I can't use the phone, I'll try to send a text. There was flooding 3 years ago in Houston where people were actually tweeting because it needed very little battery and very little signal to get a tweet out. It would be tagged, and if they were in need of a boat rescue, that they could actually, that information was then out there and somebody was hopefully going to see it. The key there is you have to make sure somebody's listening. So when we talk about communication plans, the idea is that you're going to work really hard on this and you're going to know something's not going to work. You have to plan for, if things are working fine, what's the best way for me to communicate with people? If that's not going to work, what's my next option? You kind of want to go one step beyond what seems like the most outlandish thing. And we always suggest if you had to go to a no power, no phone situation, do you know where to send somebody with a piece of paper? The old school pencil and paper, sometimes that's what it comes down to. But you have to understand that in a crisis, those things are going to break. A good example recently was it was Harris County, which is Houston in Texas. After Harvey, Harris County was the first place in the country to really look at how well radios for responders, healthcare organizations during an emergency, how well they work together. And they knew they didn't work together very well. So they had this huge project for interoperability so that if there's an emergency, everybody can talk to each other on the same frequency. They distributed over 1,000 radios during the event, so everyone had one. So even the facilities that may not have purchased one or owned one had one available to them to use. And they all worked on the same channel, and it was brilliant. Except nobody thought about how much strain there would be on the system to have that many more people on the same channel, and it broke the system. Which then now, instead of you design your communications to say, maybe I've got XY patients, these injuries, where do you want me to take them? And now you're going back to the model of I've got to pick up the phone and call somebody. Well, am I calling the EOC? Is there somebody there who's the Emergency Operations Center? Am I calling each individual hospital? Do I know how to call each individual hospital on a phone? Am I calling 911 to get routed? It was that really, we thought we had this taken care of, and that was almost a fatal flaw of saying, since we thought we had it taken care of, we didn't go to that next step. And it really made it a very cumbersome response, even though they had a beautiful and amazingly well thought out solution. They just missed that one important thing. So it doesn't matter how tight that solution is, you've got to go to that one next step and make sure everybody knows how they're going to operate if we have to go to that pencil and paper or smoke signals or, whatever it is, that we've got that opportunity to do it.
And you've brought us a couple of examples, 3 examples that I think illustrate that take the most outlandish thing and then go one step beyond. So I want to start with this tornado example.
Yeah, so this was back in Joplin. So this was in 2011. horrible EF5 tornado comes through, basically decimates the entire city. And they had an amazing, I mean, they knew they were in tornado country. And as I travel around and meet people, they know what their biggest threats are. And, the minute you start to say, what's the biggest? And they're like, tornado. Every briefing starts with which rooms can you go into if there's a tornado. I mean, it's just the way they live. And so these hospitals had done an amazing job planning for this. But this tornado was so big and so just headed straight for them that even the enhanced construction that they had, they quickly realized was not going to work. So there's a hospital there, I believe it was St. John's. They had done exercises recently. They had done all sorts of stuff to make sure that they were ready. But it really came down to when they tried to evacuate, there wasn't enough time. And they had patients that they just couldn't move. The tornado was coming in too fast. It was too strong. And what they ended up doing was turning around the beds in critical patients that they couldn't move, turning the beds so they were facing away from the window, put blankets over people as best they could so that when the glass shattered, they were as protected as they could be. Patients that they could move, they at least just wheeled into the hall. But without the ability to rapidly inform their staff that that's what they were shifting to, the staff had to figure out what's the best thing we can do and then communicate that through all the nurses. And they literally, I believe what they ended up doing was getting runners that just literally ran and informed the nurses. So talk about old school, you're going back to, really the most basic form of communication, but they realized that they didn't have time to use the system and had to do that just to protect themselves and their patients. And they had some fatalities, but nothing near that they would have had they gotten stuck mid-evacuation when that tornado hit with people, in stairwells and things like that.
And you also have an example here of a psychiatric hospital burning down in California.
Yeah, this was awful, and it's something that they're still dealing with. And I have to say, it's something that we don't often think about. But here, and this is one of the new provider types, are the inpatient psychiatric treatment facilities. And it's really when they were describing this, just the enormity of it really kind of hit me. So during the Thomas fire last year in Ventura County, which is just north of Los Angeles, we remember all those horrific pictures of the wildfires. During that, there was Vista Del Mar, which was a psychiatric hospital. It was picturesque. It was a gorgeous facility. It's been around a long time, and it burned completely. So they were able to evacuate the patients, thank goodness. But what they quickly found is that they didn't have another inpatient facility to put people in that had these primarily debilitating psychiatric conditions. So you can imagine that a psychiatric treatment facility is going to be different than a regular hospital. You have a whole different security protocol. You've got a different medication regimen that's probably not stocked in a hospital. And, they were able to figure some of that out. It was difficult at first to even find places to put them. So even figuring out where there were beds that were available, that was a challenge. They do monitor it, but it was such a changing situation. One of the things that I found fascinating is that even today, the hospitals there, because emergency rooms are required to be able to accept psychiatric patients if there's an imminent threat, is that hospitals are receiving patients for the 98 or the 96-hour involuntary hold. And most hospitals are not prepared to have psychiatric patients for 96 hours. That's a huge drain on staff. Again, it's a very different discipline. It requires a completely different management model. And then one of the, back to the most basic thing is, how do you even put a timer on for 96 hours? As a process, how do you decide that? Do you know what regulations are, what the patient's legal rights are? Do you get to list them as a patient in the directory? We all have to sign that when we check into a hospital if they're allowed to tell anybody. Are they allowed to have visitors? What's that protocol like? And they're still struggling with that today. And I give them a lot of credit because they're really trying to come together as a community and figure out the best way to serve these patients while not tying up all the emergency room space just because, then there's no place for people with the more typical situations that you would see that would need emergency room care. So it's just fascinating, and they've done a lot of work communicating with their partners, and I think they're sort of living what the Emergency Preparedness Rule is about to try to get them that collaborative aspect to serve the community and to help each other so that it's as stable and seamless as possible as far as the continuum of care.
And then you also wanted to talk to us about the difficulty of transferring pediatric patrons because their needs are so different.
Yeah, I have 4 kids. I would liken them to psychiatric patients at times, but if you think about them similarly, that it's a very specific specialty, and we often think about pediatric patients as, as long as we know their weight, we can dose their meds accordingly. Well, if you're talking about a mass casualty incident, anything with evacuations or medical surge, you've really got a different case on your hands with kids. So we've seen challenges, and I don't think it's directly addressed in the Emergency Preparedness Rule, about unaccompanied minors. So that's one thing. If you imagine, if a bus would crash, just how you manage children until you can match them with a guardian. But if we're talking about something where people have to be evacuated, if there's a children's hospital that would have to be evacuated, if there are a large number of children that are actually injured, you've got different equipment that you use with children. You've got pediatric size equipment that you need to use. You've got different medications that are safer for kids for sedation. You have child life specialists that may be available. And it's really similar to the psychiatric patients in that you kind of want that expertise and that equipment and that capability to travel with the patient. So anybody that's got a pediatric center, if they've got a children's hospital or a large facility, you may even have inpatient mental health care for teenagers. I know that's something that some communities have specifically. You really want to figure out how do you get that expertise to travel with it, and remember that pediatrics are as much of a sort of special needs population, especially if they're going to be part of the patient population, that you need to account for them as part of your planning.
And how can, I know that you've brought up the Yale New Haven crosswalk and how it can help organizations, comply with CMS compliance. How does that work? So what's the crosswalk and how can people use it?
So the crosswalk is it's a document that Yale New Haven put together, and it takes the existing standards from joint accreditation that people have had to meet for a long time, and then it matches those to the different aspects of the Emergency Preparedness Rule so that they can say, oh, I've already done this. It may be in a different part of the plan, or it may need this different language around it, but I've already done this. So it really allows you to get a window into how much is really left for me to do, and how do I align those 2 requirements for accreditation and for the Emergency Preparedness Rule, so that I'm not in a position of either redoing work that I've already done, or potentially having a gap or something not phrased appropriately. So, I think it's a great tool. It looks very busy because it is. There's a lot of information in there. But if you look at it and don't get scared, and then start really kind of going through it in an Excel spreadsheet, it really is quite usable, and it's one of the highly recommended tools of anybody that I've worked with have pointed people in this direction. So it's definitely something that if you have gone through accreditation, it's a great opportunity to save yourself some work and make sure all your T's are crossed and your I's are dotted.
And speaking of starting this planning, what's the best way for an organization that doesn't have dedicated staff for this, or staff that has a background in planning, to start? And how can they sell that investment to the management of their organization?
So one of the challenges with the Emergency Preparedness Rule is that there had been a published level of effort that was assigned to completing a lot of these tasks. And it really didn't align to what a lot of people experienced when they started putting these together. I haven't heard too much about it lately, so hopefully that's been sanitized a little bit so that it reflects the level of effort. But again, I would point people back to the coalition. The coalition, in a lot of cases, have been able to work together either with the county or directly with the state to have specific templates drawn up. They can help facilitate identifying planning groups. They're really there as that glue between organizations. I was down in Louisiana, and the coalitions had gotten together and said, here, we did templates for absolutely everything. Now you have it. It meets not only the CMS requirements, but it also meets our requirements as a state. And here you go, get you started. If you don't have those available to you, sometimes we're getting a little past the time where if they were going to have created those, they probably would have. But there are a lot of examples that are out there, and we're going to make sure that everybody has access to the list of planning documents and things that have already been created. The one thing I find continually is this is a very collaborative process across the country. So people are willing to share, they're willing to help, especially the larger organizations that have already gone through this and are familiar with it. They're happy. The other thing too is whether it's through the coalition or public health or a large hospital, is talk to them and say, how are you guys addressing, we'll say specifically your exercises? Can we participate with you? And they're going to have to do it anyway for their accreditation. But you can let them sort of take the lead if this isn't your forte, and just make sure that you're meeting the obligations by participating with them. And that's really the best advice I can give is trying to embrace that community aspect of it and see who else you can do these things with.
And so you've brought along some resources to help organizations get started here. So we've got 2 slides worth. This first one is some overview resources. Do you want to describe what some of these are?
Sure. So ASPR Tracy, ASPR is the Assistant Secretary for Preparedness and Response. That's the preparedness arm of Health and Human Services, a sister organization to the CDC. Tracy is an information exchange where people that are dealing with any sort of preparedness issues, whether it's CMS Emergency Rule or many other things, can go and look and see what other people have done. It's a very usable site. It's not cumbersome. You can request if anybody has a template of a communication plan that you could share, or, hey, I'm a long-term care facility. Does anybody have any advice? It really is a great resource. So I highly recommend that. The next link there is on Tracy, but that's the direct link to their CMS resources overview. That's a bulleted list with hyperlinks directly to planning documents that aren't necessarily ASPR documents, but I believe the Yale New Haven, which we have on here as well, has they've got all sorts of stuff on there, and it's several pages, I believe. So another great resource. And again, then it's vetted and it's been approved by ASPR, who's really trying to promote understanding and facilitate people, getting this work done, not just throwing their hands up and running away. The COOP and Continuity Guide, if anybody does business continuity planning, COOP stands for Continuity of Operations. Sometimes that's the more government phrase. That's a really good guide that ASPR put together, and that's up on their public health site. Mass General up in, obviously, Massachusetts, their Center for Disaster Medicine is phenomenal. Now, you can ask them if they can help you. You can see the link says rural consulting. But they also have a lot of stuff published that you can use at your leisure. It's freely available. So I highly recommend that resource as well. They put a lot of time and energy into that. And then we just have the official, you've got the rule guidelines and then the link to the actual Federal Register where the rules came out. Healthcare Ready is another one. It's a nonprofit out of Washington, D.C., but they're really on the side of healthcare organizations. They used to be, Ready RX, I believe, and then they've really grown into an advocate for healthcare organizations. So this is a knowledge center that they put together, again, just to share information.
Great. And you also brought some tactical resources to help people, implement these plans.
Yes, yeah. So the Yale New Haven crosswalk is there. That's in a PDF format, but you'll see it looks a whole lot like the original Excel spreadsheet. And then as far as the, sample plans and procedures, I frequently get emails of, do you have a sample plan? The California Hospital Association has done a really good job of putting some stuff together. You've got a link here that'll help you. Again, it's freely available, but has examples of a lot of different plan types. And some of them are as easy as dropping in, your organization's name and making sure that the rest makes sense to you. CMS actually has a preparedness checklist. I find that really helpful. Some people hadn't seen that before, so I wanted to include that here. The conversation and executive leadership toolkit, this is really where you get into that conversation of how do I make this a value proposition to my leadership and get support for this. And when you're, this is by the California Department of Public Health, again, freely available, but it's something that's very helpful in that ROI conversation. The next one is fantastic if your organization has not done a hazard vulnerability analysis. Again, it's an Excel spreadsheet. It lets you identify the threats to your facility itself, and it goes ahead and ranks the things that you most likely should be planning for, mitigating against. I highly recommend that. There's the first version, which has tabs across the bottom that say, it sort of categorizes it as like a natural disaster, or technological or man-made. And then the second version, they're all sort of together, but they both have their merits. So if that's something that you're facing of taking a look at your HVA, I recommend both of those. The next one are, again, California does a lot of planning and sharing. This is a link to another set of resources that they've got out there. And Wisconsin is another state that went ahead and did preparedness, the template type formats for their state, so that healthcare providers could just pull that information. So that's another resource that some people have found helpful and has a wide variety of toolkits that are available.
Great. So now we're going to take any questions from the audience that you guys have for Meg, and we've already got a couple. So Meg, are there any grants that you can apply for to help offset the costs associated with this planning?
At this point, there are not grants that are available. One thing, though, with the planning with the other organizations, you can really offset some of the costs, especially if you've got your fire department, your police department, public health, hospitals are going to have to do these exercises anyway. So if you can kind of latch on, that's definitely going to be an advantage. And then reducing costs is certainly something that you can use the templates to do. And one of the best savings that I've heard from people who have gone through the survey is marking your plans almost with like tabs with sticky notes. So don't rewrite your whole plan, but just go through and put a tab or a flag where something meets one of the requirements. And when the surveyor comes in, they can say, okay, I need to see this. And they'll tell you which number it is, and you can just go through, find that tab and say, here it is. And then you're not starting over. So one of the things we always caution is even though these are requirements, they don't need a new plan. So it's just to make sure that these things are already in your plan, if that makes sense.
Yeah. And are there any tips from the training you do for surveyors that you can share with us?
Yeah, so one of the things I can tell people is that the surveyors are on the side of the facility. They're not coming in there like an IRS audit. They're not coming in there to find things wrong. They really want to help you. The other thing that I will say is that there is sometimes a disconnect between the opinion of one surveyor and another, because this is so new. There is a lot of nuance in here that we just haven't, addressed everything. There are, you can reasonably come back to a surveyor and say, this just doesn't apply to us. This just doesn't, we had one organization that had a large campus. And when the surveyor came, he said, you need this, all these plans for each individual building. Every rooftop needs their own set of plans. And he's like, some of these roofs are just, one doctor and a nurse. I don't need. So there's definitely that way to go back and say, I'm not really sure if this is the best solution. What we have seen, and I can't guarantee this of anybody, but if they are found where they're not in compliance on something, they're basically given a remediation period where they say, all right, here's what I want you to be able to demonstrate, and then they're able to have a period of time to whatever it is to mitigate that deficit. It's not a, oh my gosh, the money's cut off tomorrow and now I'm in trouble. So it's definitely more of a partnership approach from the surveyors. They want to help you, and they'll, if there is something to mediate, they will help you understand exactly what they're looking for and how to meet that. They're not just gonna, we haven't heard of anybody that's just gotten, a black X and they say, nope, you're done. And it certainly isn't the opinion of the surveyors and the people who have gone through the surveys that we've heard anything close to that. So I hope that alleviates a little a little fear in some of the people that are still waiting for their surveys.
And this is a really interesting question. So this still speaks from the emergency management side of the house, focus on hazard. When will CMS harmonize communications with continuity management side of the house, focus on recovery of prioritized functions? One cannot focus on the hazard and the business recovery steps at the same time and expect to do both disciplines well.
The one thing that we try to, I think at least for me, helps frame it a little bit better, is looking at what are the threats to your organization, not necessarily as the tornado, but is it the loss of power? Is it the loss of access to an EMR? Is it loss of communication? Is it patient tracking? What is it that's most concerning, that's the biggest threat to your organization? And you're right. I mean, if you're dealing with responding to a hazard and coming back and doing your business resilience to try to get everything back, they are going to be not necessarily, they're going to be parallel tracks, but they're going to have different focuses. I think the thing to look at is that while the overall spirit is to have the protection of business property and the facility and return to business, protecting patients and staff as the main focus, this shouldn't overshadow any of the business continuity work. And they should be working somewhat in harmony of probably things you would be doing naturally anyway. If you've got damage to a facility, you're going to be taking care of those folks who may have been affected, canceling elective surgeries, whatever. But then you're also going to be working to figure out how to start bringing revenue back in. And I think to think more about the spirit rather than the letter in that sense, and making sure that there's as much harmony between an emergency plan and your business continuity plan as possible. But there is overlap and there is going to be disconnect. But I think from the surveyor's perspective, they really want to see this idea of beyond your roof, beyond your four walls, and how best to integrate those other community partners so that you can do both of those things as quickly and as effectively with as little impact to your patients and staff as possible.
Great. And we have one last question here. For healthcare providers that are just getting started with their emergency preparedness, are there any healthcare provider specific resources, specifically for psychiatric facilities or organ procurement facilities, etc.?
There certainly are, and a lot of those tools, some of the toolkits will have something specifically. I would say anything that is state-based is going to be far more likely to have individual-specific provider types. The best thing I can say is that you are not alone. There are a lot of people that haven't started or are definitely behind where they had expected to be. But I'm always certainly happy. You guys, I think you can see my email address on there. If there's something specifically that you're looking for, certainly can try to dig something up that's specific to a provider type. But I think those toolkits, at least one of them should have access to that, and the other would be the disaster health or disaster medicine at Mass General. I think they also have the specific ones for provider types.
Excellent. Thank you so much, Meg, for your time today. This was a really engaging and informative conversation, so I really appreciate it.
No, it was great. I hope it was helpful, and I know this is a big topic for a lot of people, and we're just trying to make it a little bit more straightforward and really get out as many resources to help as possible, and make it seem a little bit more manageable. But I know it can seem daunting. I can just say that a lot of this stuff you've already done. It's just maybe in a different language than what you call it, but you've probably already addressed a lot of these.
And speaking of getting out resources, we're going to be following up with a link to the recording of this webinar in your email tomorrow, and also an invitation to download an ebook called 10 Actions Healthcare Organizations Can Take to Improve Their Emergency Preparedness and Communication. And this ebook, in addition to containing a bunch of extra information, will have all of the links that that Meg brought. So all of those resources that we talked about earlier for background on the CMS rule and tactical advice for implementing your plan. So look for that in your email tomorrow. And also look for an invitation from us for our next webinar, our Cyber Threats and Emergencies Separate Part of Your Alerting Strategy, Why You Need a Centralized Crisis Management Center. We're going to be speaking with Jeff Trask. He's incredibly knowledgeable about emergency alerting and one of the clearest thinkers that I've ever spoken to on this topic. So I am really excited for this next webinar. And a little bit about us. AlertFind is an emergency notification system for business continuity professionals. You can see it in action by requesting a demo through our site, or you can email me, Danielle Ricci at alertfind.com. Thanks so much, everyone. Thanks for attending our webinar. And thanks to you, Meg, for joining us again.
I appreciate it. Thanks so much.